have two parts. That's protozoas and the helminths. Now we are just talking about note that we are just talking about parasites that are causing an issue in the GI level. That is the gastrointestinal parasites. We are not talking about all the parasites possible because I want to keep this video short. Usually parasites that are asked are also asked regarding the GI because they are the most common types. So before we get into the helminths, let's just look at the protozoas. And the protozoas that we have is divided into three phylums. We have the Sarcomastigophora, we have the Coeliophora, and Apicomplexa. Now, Sarcomastigophora is divided into again two, Sarcodina and Mastigophora. Sarcomastigophora is how it's named. So Sarcodina, Mastigophora. We obviously have Apicomplexa and we have Coeliophora. Now, the Apicomplexa are non-motile. Okay, and the Sarcomastigophora are motile. Okay, Sarcodina is motile by a pseudopedia. So pseudopedia. And Mastigophora is by a flagella motility. And Coeliophora, okay, is cilia motility. Okay, this is just some basics before we get into, not so important. So let's just directly jump into the most important protozoa that we have. That's E. coli. Well, this was a deliberate mistake. It's not an E. coli. That's what most of us make a mistake. It's actually Entamoeba histolytica. Okay, so Entamoeba histolytica is one. E. coli is definitely not a protozoa, but it's the bacteria E. coli, a gram-negative bacteria. And that too has the symptoms of diarrhea. That's why it's usually confused at the first go. So I'm making it pretty clear that E. coli and E. histolytica is two different things, two different entities, which are very, very different. And I, as a second year student, used to get confused a lot. So that's why I was just trying to make this clear. Okay. So let's talk about what does it cause. It causes traveler diarrhea. Okay. So is it the most common cause? It's the one of the most common also cause of traveler diarrhea. But the other one is E. coli. So the most common cause probably might be E. coli, but you also have traveler's diarrhea that is caused by Entamoeba histolytica. Okay, and also the Giardia is another parasite that can cause traveler's diarrhea. Also, you can have Cryptosporidium, that's another parasite that can cause traveler's diarrhea. So that's very important. Okay, it has a small infective dose. Okay, most of them have small infective dose. Even Giardia has a small infective dose, so you should remember. Even Cyclospora, Cryptosporidium has a small infective dose. So if you want to eliminate, will chlorination help? Chlorination never helps. They are resistant to chlorine. Okay, so before anything about the traveler's diarrhea or the symptoms, let's just look at the host. So which host does it has? Does it have two hosts? No, it has one host. It's humans. No animal reservoir. Habitat. What is the habitat? Habitat is the cecum and colon. And colon of what? Of humans, obviously. It's in the cecum and colon of humans. So this is one important point. So it goes out in the feces and is taken by a fecal-oral route by contaminated water, food, etc., or even finger to mouth. However, so that is the mode of transmission. So this is indirectly the mode of transmission. Fecal-oral is the mode of transmission. Okay. Now let's look at the stages. So I'll tell you, there are usually most of the parasites and most of the protozoal parasites that we look at. We have a cyst phase and we have a trophozoite phase. These two phases are usually seen only. They are mostly seen. So what happens is that here we have a quadrinucleate cyst. Fair enough. And the quadrinucleate cyst is the cyst that we ingest. So when you ingest this quadrinucleate cyst, okay, they bypass the gastric acid because they are resistant. So also with chlorine resistant, you should write acid resistant, acid resistant as well. So they bypass the gastric acid and they reach the small intestine. And when they reach the small intestine, there is this particular enzyme called trypsin, which causes exist. Okay, and they form something called as a metacystic trophozoite. And this metacystic trophozoite is the invasive form, as in it is the invasive form or the disease causing form. That does not mean it invades the gastric mucosa. It simply means that it's the disease causing form, and it looks something like this. Okay, this metacystic trophozoite, and it has an ectoplasm, it has an endoplasm, it has an eccentric nuclei. Okay, it has a phagocytosed RBC. So I should have, so let me draw the eccentric nuclei in blue, a phagocytosed RBCs. Okay, very, 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 very important. Okay, it can have a phagocytosed RBCs also. So what do you call it? We call it a erythrophagocyte. So if a question is asked that, which protozoan parasite has an phagocytosed RBC with eccentric nuclei, with endoplasm, with ectoplasm, endoplasm being granular, ectoplasm with fine chromatin, you have to think about obviously your metacystic trophozoite. After that, it goes into again the pre-cystic stage. And where does this occur? The pre-cystic stage. Well, when it reaches the cecum and colon, it becomes a pre-cystic stage. Okay, so it has your single pseudopodia, single, and obviously your nuclei, and then again the encyst stage where you're actually forming the cyst. So it'll form a uninucleate cyst. Okay, one nucleus. Then it'll become a binucleate cyst, obviously. Binucleate. And then in the end, again, it reaches the quadrinucleate cyst, which is 1, 2, 3, 4. Okay, simple as that, quadrinucleate cyst. But the uninucleate cyst has two important things that I need to speak about. It has chromatid bars and it has a glycogen mass. Okay, so the chromatid bars are obviously the one that are formed by the chromatin. So they are the chromatid bars, and there's obviously a glycogen reserve. But again, not super important. The only important thing is to remember that quadrinucleate cyst is the ingesting, something that you ingest. Also, the metacystic trophozoite is something that you say that is causing the disease. So it's the invasive form. And what you see in the stool is again the cyst. Now, what kind of cyst? It can be a uninucleate cyst, or it could be even a quadrinucleate cyst. Can you see trophozoite? Definitely, you can also see trophozoites if the stool is watery. Okay. So if the stool is liquid, you will see trophozoites. Okay. And if the stool, why will you see trophozoites if the stool is liquid? See, this because the trophozoite is in the small intestine, and because of liquid stool, all of these trophozoites, probably because of excessive secretion at the small intestine level, all these trophozoites are washed out. What if it's a solid stool? If it's a solid stool, you'll see cysts, and mostly the quadrinucleate, because as I told you, it's found in stool most predominantly. Now, what about the disease? Let's talk about the disease itself, the traveler's diarrhea, and the other diseases as well. Okay, so 80% of them who have the cyst in the intestine are asymptomatic. The 20% that are symptomatic, they have amoebic colitis. Okay, they can also have invasive colitis, and because they have invasive colitis, they'll obviously proceed to amoebic dysentery. And then 5% of them can actually reach the liver, lungs, brain, and they can lead to liver abscesses. obviously other lung abscesses, brain abscesses. So they are called extraintestinal manifestations or extraintestinal amoebiasis. So let me just talk about if it's an asymptomatic amoebiasis, what do you do? You treat. How do you treat? How do you treat? You do paromomycin. Simple. Not so important. But let's come to the intestinal or amoebic colitis or intestinal amoebiasis. What happens is that these trophozoites that we'd spoken about, okay, those trophozoites, they have something called as a nac lectin. GAL-NAC lectin. Okay, so what they do is that they bind to the host colonic cells. So they'll go bind to the colonic cell, and they cause its apoptosis. And when they cause this apoptosis or they cause damage, we call this phenomenon as tragocytosis. Okay, and what it does is that it kind of, let's say if this is the mucosa, it'll come here and it'll nibble it. It'll nibble and it will slowly, steadily decrease the entire cell, and it will cause its tragocytosis or apoptosis. Okay, so it'll become something like this from the original cell. Okay, so that's tragocytosis. And this tragocytosis is the parasitic nibbling of the mucosal cell, and it induces caspase 3. Then caspase 3 is induced. Caspase 3, that is your apoptotic pathway, and then apoptosis occurs. Also, this invasion of trophozoite is by cysteine protease of trophozoite. So here there is one important cysteine protease enzyme as well. As I showed, gal-galnactin is like a nibbling. We also have cysteine protease, which actually is going to help which is actually going to help invade. Okay, so cysteine protease. Now let's look at the features that you see. Okay, this is a very classical thing. We see a flask-shaped feature, ulcers. So flask shape is like this. How does a flask look? Correct. So it's just in the shape of a flask. So you have flask-shaped ulcers. Let me just write it. Flask-shaped ulcers. And where am I looking at? I'm looking at the colon, obviously. Okay, and the most common site obviously being the cecum. Okay, so even at the cecum, so the most common site is going to be the cecum, and you can also have colonic involvement, and you'll have flask-shaped ulcers. Okay, also you'll have diarrhea. You will have you could proceed to dysentery. Dysentery can occur, called as amoebic dysentery. And the complications of these are that because of infection, there can be intersusception. As you know, intersusception is where the proximal bowel enters into the distal. That can occur. Also, perforation can occur. Okay, in intense cases. And then obviously, if perforation occurs, you'll have peritonitis. So that's a no-brainer. Also, if let's say the amoeba somehow reaches the appendix, so it can cause amoebic appendicitis, because cecum and appendix are in close proximity. I hope you know that. So that is one. So you can also have amoebioma, which is a palpable mass. You can have a palpable mass because of regeneration of the ulcers and then forming a mass. Also, the most important is that extraintestinal manifestations. Now think about this. This is your GI, okay? Here you have your metastatic trophozoite. Somehow it reaches into the portal tract. Somehow, as in because of portal circulation. Now, when it reaches into the portal tract, what happens is that it reaches the liver. When it reaches the liver through the portal tract, what it can do is that it usually goes into the right lobe. And also in the right lobe, in the segment, this is 4A, 2, 3, 4B, 5, 6, 7, 8. So it reaches the segment 7 of the liver. Okay, so when it reaches the segment 7 of the liver, and it goes and it forms an abscess. Okay, it forms an abscess, and this abscess, okay, so if this is the portal hepatic vein, if this is the hepatic vein and this is the portal triad, here there are hepatocytes that are lined. Okay, all right. So because these hepatocytes that are lined, what it does is that it occludes the hepatic venules. It reaches from the portal tract, it occludes this hepatic venule. Okay, so let's say if this is the cyst and it occludes the hepatic venule, it slowly reaches and it occludes the hepatic venules. So what it causes is it causes an abscess. Okay, it causes an abscess. Now abscess has at the center there is going to be pus. There's going to be pus, or we call it as ancre sauce. Ancre sauce, pus. So this comes as a classical, one-liner that, oh, which disease has an ancre sauce pus? Well, that's it. Ancre sauce pus is by this, and what happens is that these abscesses, when they reach the portal hepatic vein, okay, they cause occlusion of the hepatic vein, right? They cause occlusion of the hepatic vein. So because they cause occlusion of the hepatic vein, there's going to be a lot of pressure here, which is going to cause pressure induced necrosis, okay, of the hepatocytes, and then abscesses will be formed, and those abscesses, okay, they are going to have a lot of necrotic pus that's also going to be present at the innermost, and which is called as ancre sauce. Okay, so what is going to be the symptoms if this condition is actually occurring? If there is going to be an abscess, you're going to have right pain, dull pain, okay, radiating to the right shoulder, okay, and also you're going to have hepatomegaly, okay, you're going to have fever, point tenderness. Now what is going to be the complication? Let's say this ruptures, okay. Now that's again important to understand each and every complication. You don't treat it, it ruptures. Where is it going to rupture? It goes up into the diaphragm, thoracic amoebiasis. It comes down, it can cause peritonitis. It goes out into the skin, it can cause skin wall abscess or skin wall rupture or amoebiasis cutis. Well, it's rare again, amoebiasis cutis. Very important to know that, okay? And obviously, if abscess ruptures, it can enter from peritonitis, can cause peritonitis. But again, that's again peritonitis. We say that peritonitis is mostly by bacterias like E. coli, Klebsiella, gram-positive bacteria like staph. Especially if it's a penetrative, it's going to be by staph aureus. So that's why peritonitis I would not think of. But thoracic amoebiasis, definitely it can lead to various abscesses, pleuropulmonary. It can lead to empyema, pus in the pleura. It can also lead to pericarditis. Now these are some severe complications, okay. Now these are some like very severe complications that we are looking at in a very further untreated patient. The patient is just not agreeing to treat the case of an E. coli, an E. histolytica. So this would occur in that kind of a situation, not in all situations. If the rupture occurs, it can lead to brain, even the urogenital tract abscesses and stuff like that. As I've said, I do not think that stage will be reached unnoticed. Okay, so a brain abscess, or urogenital abscess, all of these wouldn't be unnoticed. You'll be noticing this way before. So then how do you want to diagnose it? Let's say a patient comes to you early, okay, in this, let's say at a stage of amoebiasis only, okay. He comes to you with just dysentery, or probably with flask shaped ulcers in the colon, or let's say if he comes directly with apoptosis induced diarrhea. So how do you diagnose it? You do simple. You just do a specimen of the stool. You take the specimen stool, and then you do microscopy. Okay, you do microscopy, or you could do a culture. Obviously, you would do for microscopy. And in microscopy, you could either see the cyst. Microscopy, you see cyst, or you can see a trophozoite. But let's say if you yet are not sure about it, you want to culture it. Okay, you want to culture, and you culture it on an anexic media. So there are two media, axenic media and polygenic media. So there is one Diamond's media, and polygenic media is your Craig's or Robinson media. Also, the stool usually has a lot of RBC. It has mucin because it's a large intestinal involvement. It will also have charcoal Leyden crystal because of the amoeba entamoeba histolytical infection, which is a parasitic infection causing eosinophilia. So you'll have that too. Okay. Also, you can check for antigen, but that's ELISA, or do an ICT that's called as triage parasite panel. And now the ICT and the triage parasite panel, I just need you to know parasite panel. You're going to have E. histolytica, you're going to have Giardia, okay, and you're also going to have Cryptosporidium. So these three are the disorders we are actually going to discuss. Now we've spoken about E. coli, okay, we've spoken about E. coli. Let me just talk about the treatment of E. coli, and then we'll move on to Giardia and Cryptosporidium, because these are the only parasites, protozoal parasites, that are actually involving the GIT. Alright. So you do ELISA or ICT. In ELISA, what do you want to detect? You want to detect the protein that I spoke of, the protein that causes nibbling or phagocytosis. That's called galgalnac. Galgalnac. I like the name. Easy to remember. Galgalnac. Okay. Do PCR. Do serology. Serology to check for antibodies. They will come. They'll develop, but they are not the best. Okay. Antibodies here we do not check. However, in viral cases and all, you obviously check for antibodies only. But here they develop late, so you do not check. Okay. Also, if there is a abscess here, you do a CT, you do a CCT, you do an MRI, you do a CT, whatever. And here, if you aspirate the pus, make sure that there is no inflammatory disorder. Okay, so keep epinephrine and stuff at the site to treat that. How do you want to treat this entire condition of amoebic colitis? See, when it was a 80% asymptomatic case, we did a paramomycin. Now, when I'm saying it's a 20% symptomatic or it's the complicated case, what do you want me to do? You want me to do a metronidazole. Simple. How do I remember this entire case? Patient